Today, I'm going to share with you these posters that I saw during the last Hospitalist Medicine conference. This is within the Society of Hospital Medicine conference that happened last week in Nashville. And so I told you about this before. So in hospital medicine, there's a couple of societies that are very representative of this branch of medicine. And remember, hospitalist medicine can be for family practice, internal medicine doctors, gynecologists, or even surgeons who are hospital based mainly. With all this say, these conferences, like any conferences, are also open to residents and students, medical students. And one thing that this conference offers is the possibility for students to present posters, their research, and contribute to hospital medicine, to medicine in general. And what I want to achieve with this is for you guys, the IMGs that are preparing to apply to this next cycle and are thinking, should I do some research? What kind of research should I do? I don't know anything about research. How am I going to start doing anything, something? So for you, I want to say that you don't need big experimental research. Probably you don't have time to do that. You have to also focus on studying. So by showing you this, I'm going to show you that a lot of the research that is done during residency is not necessarily groundbreaking, trailblazing, or experimental. A lot of the research that is done in during residency, it's about things that are part of community medicine, about social determinants of health, or common problems that we have in hospital medicine, like readmissions or medication non-compliance. So pay attention to these titles. This is going to be a long video, so get ready. Let's start with this one. Comparing oral case presentation formats on internal medicine inpatient rounds. So this study, uh, the objective of this study was to assess the perceived benefits and drawback of events overnight assessment and plan compared to the SOAP note among learners. And what was the result, the conclusions? Our respondents prefer the EAP to the SOAP process or SOAP presentation. This is something that varies. Usually we use the SOAP note, but some people may like to use the other presentation format. Um, is this groundbreaking? I don't think so. I don't think that this really changes things. The EHR, EMR are going to continue to present or tweak your notes the way that the system or the hospital requests for this to be done. So, I mean, it's great. It's great because it's a great study. It's a great poster because it brings up a little bit of information on um, what the preferences are. But it's simple. I like it, but it's not something that really changes my life. Next one, diagnostic process failures associated with diagnostic error in the hospital. You guys can read it, but the conclusions mean DPFs were significantly associated with diagnostic errors cases overall and across 6 to 8 domains in our stratified cohort. This one seems a little complex, but the title is good. Diagnostic process failures associated with diagnostic error in the hospital. This is good. Next one. Frequently hospitalized patients' perceptions of support received as they cope with chronic illness, a qualitative study. So the perception of the support received by a patient that is hospitalized. Interesting. So you guys should read about this, what they did. I'm thinking that it was about the doctor giving or showing some support, maybe connecting to social workers, case workers, and after the end of this, surveying the patients and asking them how did they feel about these interventions that were given during the hospitalization aside of their medical care. Next one, evaluation of hospitalist performance on a patient satisfaction survey, comparing the mean score with results using top box percentage. Sounds sounds okay. No, it's nothing. It doesn't really catch my attention. Next one, diverse identities and workplace experiences reported in setting of healthcare and education. Yeah, sounds okay. Perspectives about COVID 19 among obese African Americans hospitalized during the pandemic. This is good. Whatever this one is, this is good, and you can replicate this in your home country. You can go to Peru and say, perspective about COVID 19 among obese Peruvians hospitalized during the pandemic. And you are giving a lot of useful information. So, see, this is simple. Next one, safety of investigational microbiota based live biotherapeutic in individuals with recurrent Clostridium difficile infection, data for 5 prospective clinical studies. And I think this is a little more advanced. This is experimental for sure. And I think I went to the dinner that this company um, sponsor. Yeah, this is by Ferrin, and yeah, I went to this dinner. So this was done by a whole group of researchers, not by students. The other ones, most of the posters are made by students or residents. Next one, prevalence and epidemiology of non-alcoholic fatty liver disease and concurrent diseases among U.S. populations. This is good, and this is just I'm gonna be sincere. You can do this just with research, like investigation of available data or whatever literature is available. Next one is multi-center experience with tocilizumab in patients hospitalized with COVID-19 in the upper Midwest. And this is done by residents. Next one, stigmatizing language in behavioral alerts was more likely for patients who are unmarried, younger, publicly insured, or those with a psychiatric diagnosis. This is not the title. No, the title for this one is Disparities in Use of Stigmatizing Language for Behavioral Alerts of Hospitalized Patients. See, this is about a topic of something that is identified as happening in a hospital. Disparities in use of stigmatizing language for behavioral alerts of hospitalized patients. And this one is interesting, so I'm going to try to read to you what it says on the background. Is background use of stigmatizing language is common in clinical documentation. It is said disproportionately in vulnerable populations and can perpetuate implicit bias. It is unknown whether it is used disparately in highly visible behavioral alerts. Methods. We collected all behavioral alerts placed for patients admitted to or discharged from the University Division of Hospital Medicine Services between 2016 and 2021. Wow. We define potentially stigmatizing language as the use of specific words or word fragments, including abuse, aggress, pain seeker, user, frequent flyer, narcotic, things that we use commonly in documentation. And we compare prevalence of stigmatizing language based on age, sex, race, ethnicity, marital status, presence of a psychiatric disorder, or insurance type. Results: patient encounters 45,000, patients with behavioral alerts 400, presence of stigmatizing language 260. The results that you see here: odds ratio, confidence interval, conclusions. Our findings are consistent with previous literature on the bias application of behavioral alerts, and given their prominence and semi-permanence in the patient chart, our research suggests that behavioral alerts may further discriminate against already vulnerable groups. Did we know about this? Yes. Did this article or study change something? No. But it was done. It is important for the current state of medicine. It is important as it is part of the social determinants of health. So it is relevant. It is very relevant, even if it doesn't do anything to what we already know. It brings attention, it brings awareness, but it doesn't change my practice, but it is relevant. And this alone could get you into residency. The other one is assessing for difference in opioids administration during inpatient end-of-life care for patients with limited English proficiency. The result was that there was no significant difference in opioid administration based on English proficiency for patients receiving end-of-life care on a hospital medicine services after adjustment for additional demographic and clinical characteristics. This is great, yeah, because some, let's say you have a Hispanic patient versus having an English speaking patient. Um, would you think that the Hispanic patient that only speaks Spanish will receive less pain medications as he's not able to sometimes get the message through? So this seems like a good and interesting study. I let you guys research it online and see what you find about it. But this is something that you should look into. There's a QR code here, so hopefully you are able to get it. Um, but anything palliative care, any study palliative care is good. So let me pull the information for you here. Okay, next one. Patient understanding of their care during hospitalization, roles, responsibilities, and mixed messages. Simple. Patient understanding of their care during hospitalization. Simple but powerful. This is the the base. This is the core of patient-centered care. If you have anything, and this can be done in your country, this can be done in a little city in Egypt, in a little town in Peru. It doesn't need to be done in the United States to be valid or significant for your application. You just need to do it. You just need to do what is needed and know the message, because you're going to be asked, why did you decide to do a study on the understanding of the care that the patient receives in this little community uh, clinic in Peru? Why? Or maybe because you really did wanted to know if a patient, how many patients really understood the indications that a doctor provided. Why? Because how is relevant? How is this relevant? Because readmissions to hospitals happen because patients at discharge don't understand how they have to take their medications. Okay, next one. Um, a slam dunk net rounding interventions improves the efficiency of hospital medicine teaching rounds. Um, this is obviously done by a student or a resident, and it is good, it is very important, and it doesn't change my life. So, but if this is something that you can do, well, go for it. Next one, comparison of hospitalist morale in a COVID alternate care site to conventional hospitals in Maryland. Comparing hospitalist morale in a COVID alternate care site to conventional hospitals in Maryland. How important is that? It's very important actually because burnout in medicine is getting worse and worse. So it is important. It is simple to make. I say simple because the title sounds simple, but I'm pretty sure it's very demanding. Has created a lot of work and effort to the presenters. So it is relevant. It is relevant. So guys, I just want to show you that not all these studies are the ones that you're thinking. The studies about comparing medications, the studies about researching the current frame of therapy for heart failure, for COPD. No, there are other things that are getting more and more attention. Okay, next one, regional race characteristics and outcomes among patients hospitalized for osteomyelitis in the United States. Simple. Next one, safety and effectiveness of apixaban versus warfarin for acute venous thromboembolism in patients with end-stage renal disease, a national cohort study. Association between obesity and length of COVID-19 hospitalization, unexpected insights from the American Heart Association National Registry. Effectiveness of mobility score-based clinical decision support for optimizing inpatient physical therapy utilization on hospital medicine services. Analyzing the use of interpretation services for patients with limited English proficiency during the COVID-19 pandemic. Good one. What internal medicine attendings talk about at morning report, a multi-center study. And conclusions are attendings comments were predominantly focused on clinical teaching and emphasized differential diagnosis, management, and testing. Three variables were associated with significantly increased attending participation and scripted conferences, in-person format, and number of non-hospitalized internist attendees. There were substantial differences between programs in number of comments and comment duration, which likely affect the local learning environment. Age-friendly initiative, outcomes from an acute care for elders unit. That was good. Anything with the elderly is going to get attention anywhere. Anywhere, because a lot of the patients that you take care in a hospital are elderly. COVID-19 mortality among inhaled corticosteroid users, meta-analysis. Factors affecting peripheral IV awareness. I don't know what's this. Seems interesting. Temporal trends and outcomes of esophageal varices with bleeding in cirrhotic patients. Effect of inpatient breast cancer education and risk assessment on mammography utilization among hospitalized women post-discharge. That seems complicated. Dysphagia in hospitalized older adults with dementia, a mixed method study of family care partners. This is a powerful topic research. Why? Because dysphagia in hospitalized older adults with dementia. What you may not know yet as an IMG that's fresh out of school is that a lot of the care that we do is for the elderly, and a lot of those patients are patients that have some degree of dementia. And dysphagia is not something easy to treat because first you have to have suspicion for dementia being a problem. Then you have to follow the path that allows you to say, well, at this point, I think that she already forgot how to swallow or is having problems with aspiration. So I'm going to recommend a alternative such as a G tube, gastroenterotomy tube. And to do that, you have to have a conversation. You have to have uh, a good way to deliver this message to the family, getting to them to say, yes, this is something that we would like for my mother. This is something that seems appropriate and in line with her goals of care. Goals of care. You talk about palliative care with them as being dysphagia, a limiting factor for the recovery, for the quality of life. The next one is the effect on gender bias on acceptance of antibiotics stewardship recommendations from clinical pharmacies. Wow, this one is good. This one is good, something that you guys should look into if you can do it in your country. Next one, hospitalist perspective of communication with subspecialty consult services. This one's good. This one you can do in your country too. Something similar. I'm not telling you to copy or to plagiarize the work of other people. I'm just saying that the studies that they are doing are not sophisticated, head to head, medication to medication comparison, looking to the latest of management. These are problems that are important for medicine, and that primary care specialties are putting more and more attention. And if you can do it, if you can bring this, then we are in a good place. You are increasing your chances. Optimizing hepatitis C virus screening using automation in an urban emergency department. Um, who gets a serious illness conversation in the hospital? An analysis of electronic health record factors. Epic readmission risk score on admission might be useful for early systematic identification of patients who might benefit from a serious illness conversation. Basically, once you identify a patient with a high readmission score, you make sure that this patient has a palliative care conversation, and if he wants to go on hospice, then he won't be readmitted. Or at least his DNR, and he doesn't become um, a patient that we are intubating, for example. Next one, characterizing the relationship between hospital Google star ratings, HCAHPS scores, and quality. And this one seems complicated, but these star ratings that are mentioned here are very important for hospital systems. And if you get to understand this and somehow use these HCAHPS scores or quality metrics to one of your studies, or you convey that quality metrics or scores are important, and you somehow did this in Chile, Peru, Bolivia, wherever your country is, then we are looking at a person that, oh, he knows how to do this. Let's bring him here, and he can do the quality improvement projects that we have in mind. Next one, hospitalized women willingness to pay for an inpatient screening colonoscopy. This is very interesting. Risk of encephalopathy and mortality associated with baclofen, a real world cohort study. Next one, implementation of clinical practice guidelines during the COVID-19 pandemic. Lessons learned from a national survey of academic medical centers. Next one, interspecialty authoring, a quality analysis of physician interpersonal conflict at the time of admission from the emergency department. Wow. Hospital medicine focused education experience and preferences amongst early career hospitalists. Central nervous system medications as targets for hospital deprescribing. Wow. Conclusions: deprescribing more commonly occurs during hospitalization compared to before or after hospitalization, but the probability is overall low. Latent transitions analysis identified profiles of CNS med classes used, which can be help explore patients, medications, and timing targets for hospital deprescribing. Next one, this is also by the same group of microbiota therapeutics. Next one, impact of the COVID-19 pandemic on patients hospitalized with sepsis that is not due to COVID-19. Wow. Does hospital teaching status affect the outcomes of sepsis? An observational study using the national-wide inpatient sample. Seems interesting. Be prepared. Implementation of a novel telemedicine-based COVID pandemic preparedness curriculum. This is great. Implementation of a standardized admission note to improve measurement of diagnosis and estimation of expected mortality. Factors influencing the choice of career in hospital medicine among U.S. medical students. Correlation between polypharmacy and frailty among Thai older persons living with HIV. Incidence of acute ischemic stroke and TIA in hospitalized COVID 19 positive patients compared to influenza positive patients. Outcomes following emergency surgery during COVID 19 pandemic in an inner city hospital of New York City. Peripherally inserted central catheters and upper extremity deep venous thrombosis, incidence and risk factors. Clinical correlation required a radiology curriculum for internist trainees. UCLA did moving the line. A hospitalist run procedure service expedites outpatient oncology care safety. Sounds fancy. Next one, improving communication and throughput during the COVID 19 pandemic. How did they do that? I don't know. Protecting time for scholarship in academic hospital medicine, a multi institutional qualitative study. The current landscape of acute care for elders. This is great. And this is just information acquired from multiple areas. Putting together information, that's what is called the current landscape of something. Efficacy of methylnaltrexone in patients with advanced illness and opioid-induced constipation, refractory to conventional laxatives. Impact of um, baseline laxative use. In-hospital mortality in patients with asthma. Good one. Closing the loop, utilizing peer education and sharing safety solutions to increase resident error reporting. Um, Expanding the triage role at a rural academic medical center to improve regional bed capacity. Wow. The masked doctor, improving patient recognition of inpatient physicians in the COVID era. Improving patient recognition of inpatient physicians in the COVID era. This is important. Why? Because sometimes patients don't know who is their primary care doctor in the hospital because we wear masks all day. And when they leave and they ask them a follow-up survey, ask them, hey, who was your doctor? And the patients don't know. That's bad. We get bad reviews from that. I would like to read more about this study. I don't know if it's about that, um, but you should look it up and see what information you get about this one. The next one is ultrasound education with the use of high fidelity simulation technology can improve confidence and knowledge among medical students. The reason of this study is probably because nowadays the use of point of care ultrasound for improving your physical exam or your diagnostic capacity is more and more utilized. Residency programs are giving new residents a portable ultrasound device to have this as an addition to the history and physical. Next one, the continued impact of COVID-19 on hospitalist burnout. This is good. Comparison of lung scanning protocols with point of care ultrasound in COVID-19 patients. All what I said about POCUS. Next one, chest CT lung involvement on admission and outcomes in SARS-CoV hospitalizations, a systemic review meta-analysis. Next one, epidemiology of non-variceal upper gastrointestinal bleeding in patient. I don't know what's this about. Decreasing duplicate PRN medication orders for hospitalized patients. This is a big one. Next one, virtual transition of care pilot study, closing the gap between inpatient and outpatient settings. Next one, what the heck is a hospitalist? Patients' understanding of the hospitalist role and other common inpatient medical terminology. Knowing and doing, assessing, training, knowledge, and use of oral medications for inpatient diabetes management. Wow. Availability of medications for substance use disorders in state prisons in New Mexico. You could just say availability of substance use disorder in state prisons in Peru, and well, you have to find the information in Peru and create your poster. But see, this is very important because substance use disorders are big in jail medicine. So knowing how to treat patients in these very vulnerable situations, it becomes important. Some residency programs will have their students or their residents rotating in these centers. Next one is exploring diversity, equity, and inclusion efforts in divisions of hospital medicine. Next one, factors and outcomes associated with dysphagia in hospitalized persons with dementia. Risk factors for idiopathic pneumonia syndrome after HSCT. Uh, Hunger as a vital sign, an interprofessional team-based program to screen hospitalized patients for food insecurity. Food insecurity is a social determinant of health. This is a big one. You should read this one and see how is this one, how was this made? How can you work on some social determinants of health? Next one, advancing care in the home. Hospitalist home advanced care model in the home to further augment effectiveness and scalability. This is going to be a big topic in a couple of years. If you can, basically, is the home care models means that instead of the patient being hospitalized in a hospital, the hospitalist, the doctor, internal medicine doctor, is going to go to the patient's home, and partnering with nurses, they will be able to deliver medications, IV fluids at home without having this patient come to the emergency department and occupying a bed. So it will be very beneficial to the whole system, and it's something we're looking forward to. Next one, analysis of the variability across distinct questions on a patient satisfaction survey and the impact of this variability on physician percentile ranking. Very important. Gender bias in medical school admissions in Japan. An assessment of care-related social needs among hospitalized adults with congenital heart disease. Perfect. Exploratory analysis of factors associated with pain control disparities in acute pancreatitis. Wow. The impact of COVID-19 pandemic on code status. Big impact. Now, more doctors, before patients are being admitted or during the admission process, they have an in-depth conversation about code status. Very important. Next one, does obesity paradox hold true for C. diff infection? 2016 National Inpatient Database Analysis. Next one, there is no diagnostic yield of imaging for deep venous thrombosis and pulmonary embolism. Next one, an antidote for the heart. Bleh. Leiomyosarcoma of the inferior vena cava presenting as deep vein thrombosis. A quantitative analysis of patient records to improve interdisciplinary communication on a hospital service. How many future lives will you save? Gamification is an effective tool for patient safety and quality education. I don't know what's this about. Trends in high severity billing for hospitalized Medicare beneficiaries treated by hospitalists versus non-hospitalists. Building a thriving academic hospital workforce, a rapid analysis identifying key areas of focus in the field. Data versus intuition, assessing the added value of nurse judgment to early warning scores for predicting clinical deterioration. Bone marrow biopsies, the marriage of oncology and a hospital bedside procedure services. An atypical presentation of sarcoidosis limited to the bone marrow. Lights out in the dialysis center, a case of ethylene oxide allergy. A tool to measure clinicians' compassion as perceived by hospitalized patients. A tool to measure clinicians' compassion as perceived by hospitalized patients.